Top Bed Talk.
Today's talk is on frailty, brain health, and perioperative cognitive dysfunction. The research that we will discuss from our group is from the Center for Surgery and Public Health, the SHARP Research Group, which is run by myself and Dr. Zara Cooper, and it is a collaboration between the Department of Surgery at Brigham and Women's Hospital, Harvard Medical School, and Harvard School of Public Health. The research is focused on shared decision-making and patient-centered outcomes in geriatric, seriously ill, and terminally ill patients. Cognitive testing has been in the news, as we know, existing even at the highest levels of our administration. And even in pet owners, there are recommendations for keeping pets mentally sound by implementing nutritional modifications, regular exercise, and mental stimulation. We should certainly think about providing the same support to our geriatric patients. Frailty, preoperative cognitive dysfunction, postoperative delirium, and postoperative cognitive dysfunction, or POCD, will now be defined. Frailty and delirium are distinct clinical entities. Frailty is characterized by vulnerability in multiple physiologic systems. It's usually chronic. It can acutely change with stressors and is potentially reversible and often has features of nutritional deficiency and reduced energy expenditure. Delirium is an acute change in attention and cognition that can fluctuate and is reversible in most cases. It is associated with inattention, thought disorders, and altered consciousness. The time frame of delirium and POCD perioperatively is shown in this slide. Preoperative cognitive dysfunction certainly exists, although most institutions do not measure it preoperatively. Emergence delirium occurs in the PACU, and postoperative delirium occurs 24 to 72 hours post-op. Postoperative cognitive dysfunction lasts weeks to months after surgery. Some of the factors associated with postoperative impairment are associated with both frailty and cognitive dysfunction and include things like socioeconomic disadvantages, lower educational status, significant comorbidities, and low nutritional status. Those are more associated with frailty and generally impair the domain of muscular strength. Cognitive impairment impairs the domain of memory and leads to persistent cognitive impairment and, in some cases, dementia and mortality. Preoperative cognitive dysfunction is occurring by an unclear mechanism and certainly can be influenced by a number of factors, including inflammation, microvascular disease, increasing age, although exact etiologies are not definitive. The baseline before surgery can be mild or significant cognitive dysfunction, although again, unless the patient has a specific diagnosis of dementia, these often aren't measured. Delirium postoperatively, as I mentioned, occurs for 24 to 72 hours after surgery, and postoperative neurocognitive disorder or postoperative cognitive dysfunction can be mild or can be major, and in some cases can progress to persistent cognitive dysfunction and dementia. Are postoperative delirium and postoperative cognitive dysfunction part of the same syndrome? A recent study in anesthesiology, the SAGE study, looked at 560 older adults with the hypothesis that delirium is a significant risk factor for postoperative cognitive dysfunction, and they investigated the incidence of POCD within 6 months and evaluated the relationship between postoperative delirium and cognitive dysfunction. And Interestingly, there was a very poor agreement between delirium and postoperative cognitive dysfunction with very low correlations. So the conclusion is that postoperative delirium and longer-term postoperative cognitive dysfunction, at least in this study, don't seem to correlate and may, in fact, be different disorders. What is the impact of frailty and preoperative cognitive dysfunction? First, let's talk about the clinical impact of frailty. Regardless of varying definitions of frailty and postoperative outcomes, frail patients have less favorable outcomes in all of the studies. Compared to the non-frail group, the frail group had a higher risk of developing moderate to severe postoperative complications, had longer hospital stays, higher readmission rates, and decreased long-term survival rates. Frailty also increases cost. In this study, looking at increased hospital and 6-month healthcare cost following colorectal surgery, you can see the cost for the non-frail patients was less than the cost for pre-frail and frail patients. Non-frail versus frail, there was a difference between $27,000 and $76,000 for the hospital cost, and a significant difference in the 6-month post-hospital cost between $6,000 and $34,000. This is actually very important for us to understand because the Medicare DRG payment does not vary based on how frail the patient is. And there is a very small difference between the Medicare payments for non-frail, pre-frail, and frail patients, which really does not cover the actual cost. The clinical impact of preoperative cognitive dysfunction is also important, although since few institutions measure this, there aren't many studies. One of the studies that came from our group, which was published in Anesthesiology in 2017, showed that routine measurement of preoperative cognitive dysfunction shows that it increases with age and also is associated with adverse outcomes. 1 in 3 patients who are having surgery were shown to have abnormal cognitive function on an assessment test. And probable cognitive impairment was associated with worse surgical outcomes. Patients with abnormal cognitive assessments were significantly more likely to be discharged to non-home locations, had postoperative delirium, and had longer hospital stays. The impact of postoperative delirium on healthcare costs is significant. Healthcare costs related to postoperative delirium have been reported to exceed $150 billion a year. From the Society of Hospital Medicine meeting in 2019, Lau stated that we know from previous research that as many as 1/3 of hospital-acquired delirium cases are preventable, and obviously this can have a huge impact on healthcare costs. What are the obstacles for institutions to begin using frailty and cognitive assessments? And I've listed the most common ones here. First, there are many tests in both these categories. How do you decide what is the best test to use? Also, many of the assessments require patient to present in person, so that fitting these things into your institutional workflows can be difficult. Preoperative clinicians are usually not trained to perform, score, and document the results of assessments. It's not generally part of routine residency training or nursing orientation in the preoperative area, and the hospital may be unwilling to provide resources for these assessments prior to the day of surgery if it would increase the length of preoperative visits, as most require a clinician resource. Other obstacles, electronic medical records are very limited in their ability to document frailty and cognitive assessments and transmit them to downstream providers. And they also have very limited ability to document post-discharge outcomes, so the importance of recognizing frailty and cognitive issues may not be apparent. And probably the most difficult one is if the assessment does show that cognitive dysfunction or frailty is present, how do we act on the results? So as we think about developing things, working frailty and cognitive assessments into a sustainable routine clinical workflow can be daunting. It does require separate assessments, and frailty and cognitive dysfunction may or may not coexist in the same patient. An overall template would be to begin with a multidisciplinary team approach where you select the screening tests that you're going to use, train the staff to administer and score them, determine the cutoff score, develop and implement workflows based on the cutoff scores, and then begin an evaluation of the older adults presenting for surgery. What do you do if you do identify cognitive impairment? Well, some options include a nursing delirium prevention pathway, completing a more extensive workup if it will impact management, possible geriatric co-management. It certainly can influence discharge planning, and it may have an impact on consent and shared decision-making. Similarly, if you identify patients as pre-frail or frail, geriatric co-management may be considered. Prehab with optimization of specific issues should be done. And again, discharge planning and the impact on consent and shared decision-making should be considered. One of the institutions that's really in the forefront of this work is Duke, which has implemented the POSH program, or Perioperative Optimization of Senior Health, and they have really formalized this pathway in terms of preoperative assessments, preoperative interventions, and postoperative management, and they are benchmarking in this area. The data from the POSH studies shows that using this methodology, they have been able to decrease median length of stay, decrease length of stay by procedure, decrease readmission rates at 7 days and 30 days, and also decrease 30-day readmission per procedure. They have also shown that using the POSH program, more patients have been discharged home than to some sort of other home environment, and fewer patients go to a facility. In our own institution, Brigham and Women's Hospital, we are in the current development of our own geriatric surgery pathway. Unfortunately, with the beginning of COVID, this was held up, but our overall goal would be to do something similar to the POSH program in terms of delivering similar personalized high-value care for geriatric patients using an interdisciplinary approach and integrating evidence-based geriatric and palliative care processes. The preoperative assessment will include screening for frailty and cognitive issues. How do you choose the right assessments to use? The SPOCI committee for the Society for Perioperative Assessment and Quality Improvement has recently published a guideline based on a review of the literature to help us decide which test should be used. This is currently in the process of publication, and I'm just showing the proof. It should be in the literature within a short while. Based on the SPOCI recommendations, they list the possible testing and look at their utility in preoperative settings. So if you review that document, it will show you a number of tests that potentially can be used in the preoperative setting, how long it takes to administer, and where it's been studied. At the Brigham, we've chosen the mini-cog, and as I reported earlier, that test has had studies that are associated with outcomes. How do you train your preoperative clinicians to do this? We obtained a grant from the Hartford Foundation to develop and use a health stream video to teach our preoperative clinicians cognitive screening in older surgical patients. And this involved working with our geriatricians to provide a health stream-based video that includes testing and will enable our preoperative clinicians to implement and score the mini-cog test. How did we make this preoperative cognitive screening sustainable? We had this brief video training program with an online quiz. We measured the percent of undiagnosed cognitive stratification once we started using it routinely. It had no significant impact on visit length, and interestingly, the results were very similar to those that I quoted earlier from a previous study where a research assistant performed the testing. So the study validation and inter-rater reliability was very good. Just to show the results from the routine screening, the incidence of undiagnosed cognitive impairment in patients over age 65 was overall 29%. And this was pretty similar to the results we got from the earlier study where these were done by research assistants. Interestingly, the incidence is 40% in those over age 75, and as we see more and more older patients coming for surgery, we certainly need to bear that in mind. The other thing I should point out is these studies excluded patients who already had diagnosis of dementia, so these results are showing us previously undiagnosed abnormal cognitive studies. What is the impact of these assessments on shared decision-making and informed consent? Now that we understand the significant prevalence of undiagnosed abnormal cognitive stratification in surgical patients over age 65, how can we ensure high-quality shared decision-making and adequate informed consent? In our study, we did cognitive assessment after patients had signed informed consent in the surgeon's office. So I'm showing you some of the clocks that we got from these patients who had already signed informed consent at the surgeon's office. So I guess the question that I would ask myself is, looking at these clocks, do we really think that these patients are able to give appropriate informed consent, follow instructions, and do everything else that's going to be needed perioperatively if they are unable to put the numbers on the clock and make it read 10 after 11? And I'm just going to show a few more clocks in patients that already had some surgical informed consent. There are many assessment tools for frailty. At the Brigham, we are implementing the Frail scale, which is commonly used for routine screening in preoperative geriatric patients. It's pretty easy to use and combines the elements of fatigue, ability to climb a flight of stairs, ability to walk one block, illnesses greater than 5, and recent loss of weight greater than 5%. With 0 of these, you're considered robust, 1 to 2 is pre-frail, and 3 or greater is frail. Now, the pictorial fit frail scale has been recently developed and would allow us to use a visual scale to assess frailty. And this is from Rockwell's research group in Canada. The article from Canadian Geriatrics Journal in 2019 discusses development and validation. And what this scale does is it allows us to assess frailty without a clinician present from patients rating what they think about their own functional level from pictures. The test was developed using a number of methodologies, types of pictures, and formats to make this pictorial fit frail scale as as good as possible, and that article provided information on the development and validation. Why do we need a new frailty scale? The Pictorial Fit Frail Scale has been shown to be comprehensive and feasible. It appears generalizable across countries. Language, educational level, and cultural differences are no longer an issue. It has face and content validity. It can be done by a patient without a clinician present, and it does have the potential for virtual administration without an actual in-person visit. We are currently collaborating between our group at the Brigham and the Rockwood group in Canada for the first use in surgical patients of this test, and we are currently working out the details of studying the reliability and predictive validity of the scale in preoperative surgical patients. So, the recommendation would be that institutions need to develop geriatric surgical pathways to ensure the best outcomes. The American College of Surgeons has recommended this and released in July of 2019 their recommendations for optimal resources for geriatric surgery. The American College of Surgeons Geriatric Care Standards list a number of recommendations that many institutions, including ours, currently have gaps in. And functional, frailty, and cognitive assessments, as well as delirium prevention routinely, are obviously very important parts of this pathway. From our institution, we looked at the results of integrating geriatric co-managements into the routine care of older trauma patients to see if this really does make a difference. And what we found was geriatric co-management decreased the 30-day mortality rate from 11% to 6%, and in-hospital mortality decreased from 9.5% to about 5%. So in summary, assessment of cognitive function and frailty should be part of routine geriatric preoperative assessment. Interventions to target resources where most beneficial for at-risk elective surgical patients need to be developed, tested, and implemented. And we do need outcomes databases to be developed, as the important outcomes are really not contained in current databases such as Medicare or NISQIP. Thank you.
Top Med Talk.
Thanks for listening to Top Med Talk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to Top Med Talk and EBPOM at ebpom.org.